Welcome to this talk and a welcome back to Dr. Joseph Fraiman in Louisiana. Dr. Fraiman, welcome back. Thank you for coming.
My pleasure. My pleasure to be here.
Now, you are a practicing emergency physician and you're also a medical scientist and I think it has to be said somewhat of a data scientist as well. You became well known for this paper that we can see on the screen here. Serious adverse events of special interest following mRNA COVID-19 vaccinations in randomized trials in adults. Now, we want to talk about excess deaths, but a lot of people know you through this paper. So what was it prompted you to write this paper?
Well, that paper was based on a concern that occurred after what happened is initially when the vaccine was released, I didn't have concerns for adverse events. I read through the paper. I kind of took it at face value. There weren't any serious problems. Didn't look like serious harms were a problem. I kind of thought of it as generally as we look at other vaccines, and okay, it matched up. There was, I was concerned about the limited time. I had no specific problem, no specific concern about harms. And I didn't have that concern for harm until they discovered that that the spike protein was toxic, and it caused all of the weird things that I was seeing in the emergency room and that everyone was hearing about on the news. That in the early 2020s, in 2020, we went through this period where it felt like every week or month we learned about a new crazy thing COVID did. And you're like, oh, it causes heart attacks. Oh, that's weird. A virus causing heart attacks. It causes these blood clots. That's a strange thing, and none of it really made sense. But we saw it; it was real. And then we learned in April 2021, around 4 to 5 months after the vaccine was approved, we realized that that spike protein was the exact thing that was causing these problems. And I thought that was a major issue, because if they knew when they were creating the vaccine that the spike protein was the protein that was causing these terrible events to occur, they probably would have chosen a different protein to include in the vaccine to use as the messenger RNA vaccines are, which make our bodies create that toxic protein. And it's possible that maybe when our body's created and it's in the way that it's delivered, maybe that's safe, maybe it's not. But it's just, it's something that's a little bit dangerous to play with, a protein that we know to be toxic and to cause some pretty serious problems. And that was what raised my concern, and that was how we kind of started on the path of reanalyzing the data with focusing on the harms that COVID-19 causes to identify, is there actually a problem that was potentially missed in these original trials, knowing now what we know, that the spike protein is harmful. And we created this study to do that by looking at serious adverse events and then taking a special list that is called an adverse event of special interest, created by a group of vaccinologists called the Brighton Criteria, their group, and they're endorsed by the World Health Organization. And they create a list of harms that are maybe potential. Look out for these. They might be caused by the vaccine. Pay attention for it in the clinical trial. So they design it before the trial. And then we took that list and we applied it to the original data and found that there was, for those adverse events of special interest, the ones that this group said to be concerned about, when you look at both Pfizer and Moderna, there's about a 1 in 800 increase in serious adverse events in the vaccine group. And that is a highly concerning number. Even though 1 in 800 sounds maybe like it's not a lot, but when you think about that on a population level of several million people, it turns into a lot of people being harmed.
And we're talking about side effects which is serious enough for someone to come and consult you about it as an emergency physician. We're talking about relatively serious and sometimes very serious adverse reactions.
Yeah, it's a serious adverse event it's a definition, and it's defined clearly. It means death, or it means life-threatening, hospitalization, or permanent disability. or congenital defects, which in the trial I don't believe anyone gave birth, but if they had, that would be included in it if there was a congenital defect. But yeah, every one of these things it means it was quite serious. It's different than the patient thinking it's serious, because it doesn't include things that something might happen to a person that they believe is serious. Maybe the vaccine made them just feel like so fatigued and tired that they couldn't work for 3 days, and that cost them a lot of money that they needed, and that to them was serious, but that wouldn't make it into the events of serious adverse events. That would be
objective. Yeah. You're using objective criteria.
Yeah, it's objective. You have to fit one of those things. Yeah.
I must say, I've never worked this out in all these last four years. Why the people making the original vaccines did not anticipate the pathogenesis of the spike protein. They could have used nucleocapsid protein. They could have used envelope protein. They could have used probably any one of 30 epitopes on the virus. And yet they went for the one that was so toxic and the one that keeps changing all the time. So the vaccines are out of date 10 minutes after they made them. It seems like two fundamental errors.
I don't think they knew. We didn't know the spike protein was toxic when this happened. So that's not their fault. We didn't know that. We didn't know that until April 2021. About 5 months after the vaccine came out, and it's heavy mutation rate. That was definitely something that concerned me initially. Also about the vaccine, that a virus that mutates so rapidly. If you have a vaccine that chooses only one protein, it does allow for to push evolutionary changes to respond exactly to that single protein. While if you have multiple different attacks, sort of the way that we approach HIV, for example, where we use 3 different medications typically with HIV, because if you use one, the virus learns how to mutate to the one medicine because it's only attacking it on one front. And if you use 3, it's unlikely for it to gain all 3 mutations simultaneously and then be able to, break through that medication. So that part they should have just known from basic immunology, that to use one protein was probably not the best idea. It probably should have been multiple proteins if they were set on using the messenger RNA vaccine instead of a live or inactivated virus, which is how most of our other vaccines have been created. So yeah, it's not. I think there's not some major bad calls that maybe were made there, but to be fair, there was a pandemic. Everyone was just working their hardest to get to that finish line, and there were people dying, and so I think we should expect that some mistakes would be made under such a circumstance, and I think that it's not fair necessarily to discredit the scientists that were doing this and say you should have been smarter, and it was a time where we weren't all thinking exactly 100% straight, but yeah, I'd agree that it wasn't the perfect design for a vaccine in general.
Yeah, I mean, for one, evolution can quite easily generate one mutation, but to generate 3 mutations at the same time is a bit
in different proteins.
And I think you are very gracious and very forgiving in your treatment of people who have spent their lives specialising in these subjects. But
no,
we'll accept your argument.
I would say the only thing that, and it did actually concern me when they first released it, was that I was concerned that maybe they were aware of this concern that we're speaking about, that it's going to rapidly mutate. And within the pharmaceutical industry, from their perspective, actually, that isn't a negative. A vaccine that they would only have to give once is way less profitable than a vaccine that they would have to give multiple times. So, or they'd have to keep giving each time the virus mutated. So I did have some concern. And this was before, we learned that we had the waning and the boost and needed boosters every however often the CDC recommends them. And so I was a little concerned because I know that their financial interests would have driven them towards actually creating exactly the kind of vaccine that would need to be updated often. And so I was a little concerned that maybe it was purposeful, and which I don't like if that was the case. I don't know if that was the case, but we have to be honest. These guys, these are corporations that are trying to make money, and they aren't necessarily always trying to do things for the good of humanity. They are also trying to make money, and so it's possible that maybe they did foresee that ahead of time. And maybe even if you imagine the corporate room when the scientists said, if we just use the spike protein, you understand that that means there's a very good chance it's going to mutate, and then we're going to have another one that we're going to have to give to chase that. And he was saying it maybe with concern, and then the corporate executives were like, wait, no, that's actually good. And you could see that sort of a meeting happening. I don't know but who knows what actually happened.
Oh, this is completely hypothetical, of course. But,
yes. But it's plausible. I mean, I knew it. I'm an emergency doctor. I'm not a vaccine. I'm not a immunologist, or I've never created a vaccine. But I mean, it occurred to me before the immunity waned. I was concerned that this was going to happen because of that obvious problem. So it'd be hard pressed to say that the people who are the experts in this field wouldn't have thought of that problem. But it's possible that they just were rushed and just pushing it out there, and maybe by the time they realized it was too late.
A built-in obsolescence, we would call it, wouldn't we?
Yes, it is. Yeah, it's difficult to teach a man something. It's difficult to teach a man something, right? That when his paycheck depends on his ignorance of that information. And that is Upton Sinclair. I'm paraphrasing him, but it's some sort of it's a clever line.
So during 2020, you were seeing a lot of people coming in with pathologies generated by the viral infection. Were you seeing? I mean, well, firstly, what pathologies were you seeing, and were you seeing similar things that you suspected of being vaccine induced in 2021, 2022?
I don't know. It's very difficult to say because from our study, it's the serious adverse events that appeared to be increased in the vaccine group. There's a lot of them. We don't know which ones it is. We just know that combined, it's causing an increase. So what that ends up translating to is maybe 10, maybe 20 different things, each having a small increase. But these are typically actually kind of relatively common serious adverse events. So if you can imagine
things that like strokes and heart attacks that are happening that are your bread and butter every day.
Yeah, so imagine I'm seeing, for mathematics sakes, right? Imagine on average I see a heart attack once a month, right? So then I'd see 12 in a year. But some months I'll see 2 in a month. Some months I'll see maybe even 3, and then I can go 2 months without seeing one. Now, so if in a year, that means if there's a 20%, 30% increase, that means I'll see 14 that year or 15. And there's no way that I can notice that difference subjectively, because it's simply because I get months when I'll see 3 heart attacks, I get months when I see none. And so I really couldn't, it's not possible to really be certain that you're seeing it even when you're working in it every day. And the only thing that I saw that was a little unusual is that there was a handful of younger, healthy people who had blood clots in very strange places that you don't typically see. Those things do happen sometimes. And so were those caused by the vaccine, or were those just the rare blood clots that happen in rare places in these individuals? I really don't know. And it's the way I try to explain it is, if you think about it, like what happened with Vioxx, a drug we all now understand caused a heart attack. Typically elderly people were taking Vioxx because it was for arthritis, And if someone came into the emergency room with a heart attack and they were on Vioxx, I have no way to distinguish between, is that a Vioxx heart attack or is that just a regular old heart attack? And so it's just impossible to notice these things, especially what common conditions. Small changes in common conditions are very difficult to notice on the personal, like day-to-day level of physicians. They're also very difficult to notice within our surveillance system that exists. Our surveillance system can only really identify things like myocarditis is a perfect thing that it can identify. It's ultra rare. In the background, it almost never happens. I go years without seeing it, but it's it's 1 in a million type of a thing, and then if it increased by 20-fold, then you're, and it happens after the vaccine at 20-fold the rate. There's really few other things that could be causing that. That's what our system can pick up. Surveillance system can pick up rare events that were missed in the trial because we didn't do a trial with like 30 million people, and we never will. And that it could pick up rare events that have a very high relative risk. But surveillance systems cannot pick up small relative risks, even of common things, because that's what you need the only thing that can identify that is randomized controlled trials that could identify that consistently. And we saw this actually with Vioxx. A perfect example is that we didn't notice that Vioxx was causing heart attacks despite some observational data being problematic here, some a little bit there, but it's always inconsistent. That's what you would expect with small changes, a 20, 30%, 50% increase in a heart attack. The way that we discovered Vioxx was a problem is they did another randomized controlled trial where they were looking at using it to protect against colon cancer, not using it for arthritis. They were seeing if it prevented colon cancer. It did. It did prevent colon cancer. It's actually kind of impressive. But it caused heart attacks more than it prevented colon cancer, and that was the end of Vioxx. When a randomized trial identified it, our surveillance system was unable to see it. We just got lucky that they did this trial for colon cancer, and but without that trial, we'd still be taking Vioxx today, probably.
Yeah, it's the concept. So what we're basically saying is most things aren't pathognomonic. That it could be caused by a range of things rather than a specific thing.
Yeah. I mean, a lot. Well, yeah, certain things are, certain things aren't. Certain things are strange. Before we spoke, before we started our video, we were speaking and we brought up lung cancer and smoking, and that's a very specific thing. While non-smokers occasionally get lung cancer, that's really rare, and so the association there is so big that our surveillance is able to clearly connect that smoking caused the lung cancer, and it's because the connection is so obvious that what else is causing this there's nothing else that's reasonable. And when you have these small and 20, 30%, 50% increases in heart attacks, sounds like a lot, because it is a lot, but from an observational surveillance perspective, it's not a lot. Like, there's no way we could have caught myocarditis if it was increased by 50%. There's no way. We needed it to be increased by many fold, several hundred, like probably 500, 1,000% increase. That's where our surveillance data is good. But yeah. So it's something that people have a little bit of trouble with this, because people they say, we know the vaccine's safe because it's been given to billions.
Yeah.
And so your study must be wrong. In fact, actually, that's actually my group. We met with the FDA and we spoke with them. And I was actually shocked when the FDA said that to us, that we don't think your results are correct because, we are doing this surveillance and we are not necessarily seeing this. And we were like, whoa, wait a second. That you're suggesting that observational data that you have is outweighing data from a randomized controlled trial. If you took a first-year medical student who I hope is taking an evidence-based medicine class, and you ask them which evidence is going to be more reliable for identifying small differences between groups, I hope that they would get that answer right and choose randomized controlled trial on that test. And I think almost all of them would. So the FDA though was suggesting what every first year medical student would answer differently, and that was a little concerning to us. Yeah, it was a little. That's quite concerning, and they didn't seem to understand that, and we clearly didn't convince them otherwise. So they still must believe in that interpretation of this data. And oh wait, and then actually we have one more actually what the FDA said, because we asked them, what are you seeing in your surveillance data? Are you seeing, for example, our issue was they're seeing a problem with coagulation disorders, blood clots, strokes, heart attacks. We don't have a statistical significance here, but when we look at all of the data, this is the one that comes out in both Pfizer and Moderna. That's the one that's the biggest difference in both of these trials, and so we're not saying the data is overwhelming. It's just a coincidence, maybe. We're like, but are you seeing any problems with coagulation disorders? And one of the 7 of the top level FDA people, he was in charge actually of a lot of their surveillance, and he's always the head author on every of their surveillance studies. I will not name him, but if you want, just look up senior author on all the FDA's surveillance studies. He told us in that interview that, okay, yes, we are seeing about a 50% increase in heart attacks, a 50% increase in pulmonary embolism, blood clot in the lung, 50% increase in thrombocytic cytopenia, like a blood clotting disorder that essentially leads to eventually bleeding. And he's like, but we're not certain that if this is confounding, if this is, and that's the issue with observational data, is that when you have a 50% increase or so, or small, you really can't be that confident that it's true. And you're going to find it sometimes, and it's going to go away sometimes. And that's what they were dealing with. And we had to say, guys, those are the exact conditions we asked you about. And those are the ones that you're seeing the increase in. And you're saying at the same time, you're just not sure if those are real. But these data sort of are aligning in the correct way to suggest that this could be real. And that FDA advised, chief, to be fair to him, he did seem concerned actually. He said, we know that this could be serious, and we know we are trying our hardest to figure this out. But yes, of course we are aware that if this is real, this is a problem. And I could hear in his voice that he was concerned and that he was trying. So, but that's all, and that was kind of where that conversation. We asked the FDA to repeat our study, replicate it, to see if they would find the same result as ours. And that was, I don't know, 2 or 3 years ago, 2 years ago now. I don't believe that they've attempted to replicate it.
I haven't heard anything. And in the study, you said you could do a better analysis with participant-level data, which the FDA have and the pharmaceutical companies have. Has this participant-level data about the age, the sex, the vaccine status of the participants been released to you now?
It's difficult for Pfizer. You can say maybe from a Freedom of Information Act, there's thousands and thousands of pages they released. And it's possible that if someone went through it, it'll take several years probably to go through it and pull that data apart in the way that it's needed. So maybe for Pfizer, but not for Moderna. In fact, actually, for example, two of the co-authors on my paper, they researched a similar event for Tamiflu, where they were able to get multiple, data files for Tamiflu, and it took them several years to really go through it in detail to get what they needed to find, and so that's when you get handed thousands and thousands of paper that you have to comb through it really closely. It's a lot of work, and
And I
I have a
suspect that
job. I have
works.
a job. I have
Oh,
a
you
job.
do.
You know, and you know, so
I suspect
you
others have probably already done that. It's just there might be a reluctance to share that, which I would consider
oh,
unfortunate.
oh no, I'm certain that the data has already been organized
Yeah.
by the obvious subgroups, by age, and they must have done that, but that's not how they released they didn't release their data in an easy to interpret format. It's released in a very very difficult way
Yeah.
to navigate through.
Yeah. Bit like a dog's dinner. It's all messed up.
Yeah.
Now, there's no question in my mind and in your mind, I think, Joseph, that there was these short-term side effects of the vaccine. That's clear from your analysis.
I think that that's most likely the case. I think that I would be hard pressed to think of another reason why, but especially in particularly in the Pfizer trial, I think it's undebatable. There was more serious adverse events, and that's actually not using our analysis. That was a large surprise in our study was when we counted the number of serious adverse events in the Pfizer trial. There's just more. There's 36% more in there, or about 1 in 555, and people get confused. Why the 1 in 800? Why the 1 in 555? That's because these are estimates, and it's because the real number is somewhere near this. It's a range of possibilities, and if the study was done again, it would be something near 1 in 555, a little higher or a little lower. But in the Pfizer trial, without any sort of reanalysis, just counting, you can see that there's more. There's more, and that was not reported by Pfizer and the FDA did not report that. In fact, actually, in the meeting that I had with the FDA, we asked them about this, and they told us, "Oh, well, actually, we don't count the number of serious adverse events. We count the number of participants who experience a serious adverse event." And we were like, "Okay, well, that's another way to look at this. And if you do that, there's about a 27% increase in the number of participants, but it doesn't cross like a statistical significance threshold. It's just higher. It just so turns out that the people in the vaccine group who experience a serious adverse event were twice as likely to experience multiple." And what we explained to the FDA is that, we're dealing with a drug that's given twice. So I would presume if you're susceptible to these serious adverse events, that it's not random, that if you got the vaccine again, there's a good chance you're going to get another serious adverse event. And so you could have a guy who has a heart attack after dose 1, and then they're like, "Okay, man, everything looks good. I think you're ready for dose 2. You're doing well." And then has a stroke after dose 2. And that would count as 2. That would be 2. And so I think what we explained to the FDA in that meeting is we agree with them that having 2 participants experience 2 serious adverse events is probably worse than 1 participant experiencing 2 serious adverse events. I think most people can agree on that as a general rule. But I also think that as a general rule, 1 person experiencing 2 serious adverse events is worse than 1 person experiencing 1 serious adverse event. So their distinction between why our method was not accurate is I don't think that it needs to boggle down into statistical and like boringness. Everyone knows that if more serious adverse events happen in the group that you're testing, that's bad. That's simply bad. There's no way around that not being bad. And there's no statistical argument that can suggest that that's not bad. So I'm a little bit uncomfortable that the FDA thinks that having more serious adverse events in the vaccine group is nothing to worry about, because when they look at just participants having it, it's just a 27% increase in the participants, and there's no statistical difference or, clear difference between the groups. I think that that's a very I wouldn't.
Yeah.
I don't trust that. That's not a good.
No.
I don't think that they're using a fair way of thinking about. I think there should be caution. I think we should have caution when we're talking about serious adverse events.
And the level of apparent inaptitude there just seems hard to explain as well. I mean, these guys should know this.
I fear that so there's an element of certainty here, right? That's necessary to have this like discussion, right? And that what are we certain of? And that's what science is all about, is declaring when we're uncertain. And we acknowledge uncertainty is like the power. It's the power of science. You say, oh, we're uncertain here. Let's look at that and make us less uncertain and get closer to what's real. And I think that the FDA, so for harms, I think that the bar, how high you set your bar, to be 100%, I don't think that we want to set the bar at 100%. I don't want to be 100% certain that these are it. If we're 90%, 95% certain that we're causing increase in serious harm, then whoa, slow down. Like that would be a terrible thing to hear from a doctor. That being like, well, do these cause an increase in serious adverse events? Well, there's a 90% chance that they do, but we're not certain that they do. And that would be so if you have to wait even in, like, for example, the 27% increase in participants experience a serious adverse event using the statistical methods that we use, you'd conclude that it's we'd be about 90% certain that there's a serious adverse event. But the way our system works is if we're not 95% certain, then we call it not statistically significant, and it's nothing. But really if it's 90%, it just means it's 90% certain. There's nothing special about what happens between 94% and 96%. There's nothing special. It's just a little bit more certain. That's all the difference, is a little bit more certain. But 90% certain that there's a serious adverse event is actually way more than I'd be comfortable with for a medical product that I'm giving to healthy people. And
Absolutely.
So there's some issues with just maybe how we interpret statistics and how certain we demand, like for a benefit, on the other hand, for a benefit of a drug, having a 95% certainty or even higher is probably a good idea, because we really, really want to be certain that a drug has a benefit. Because if a drug doesn't have a benefit, it only is going to have harms. And so for giving a drug, the standard for giving a drug and the benefits should be higher. In my opinion, they should be higher than the standards for how certain we need to be about being concerned about a safety problem. But that is problematic, because the way our whole system has been built for 100 years is this statistical system using 95% as this threshold, which it's a silly threshold. It's not. It should be used differently depending on the thing you're looking at and when you should be concerned about a thing.
94%, there is no problem at all. There is no difference at all between the groups. 95%, hey presto, there is a difference. It's just...
Yes, it's the whole thing. P-value, statistical significance.
Ridiculous, yeah.
It is not a good system that we should be using. It's something that was 100 years ago, and it was created. It was, at the time, it was a great breakthrough of thinking about things. But I think that we're in our study, we don't even use p-values and statistical significance, because we had, the person who kind of educated me on this is a man named Sander Greenland. He's one of the co-authors of our study. He's one of the top epidemiologists of the world. And when we first did our study, I was a little bit upset, because he spent most of his career arguing against statistical significance and how it's misleading and how we should get rid of it and just talk about things in terms of what's our confidence that something is true or not. And that gives us a much better understanding of it than talking about it in a black and white fashion. And
absolutely,
I actually initially fought with him, and silly. This guy is one of the top epidemiologists in the world. The book Epidemiology for graduate students, he's the only author on it. He's the top level epidemiologist. But I thought I was right. I was convinced. I was like, no, we have to include the statistical significance, because no one's going to understand our study if you don't put it in there. He convinced me eventually, and I'm happy he convinced me. And I think I was wrong, and believe that he was correct. That we give the information, we discuss confidence, the confidence that we have on our answer. Even though it would have gotten the title statistically significant, everyone caught the message of what our study found, and that it suggests exactly the same thing. And so I was very happy we didn't that we went with his methodology on that.
Sounds like a big improvement to me.
Yeah.
It's a gradated increase in risk. It's not an on-off switch.
Yes, that's why that long side tale was when you said we could be certain that this is it. And I was saying, yeah, like 96-7% certain, but not. I don't think that we can get to. If we were at 99.9, then I'd say yes. But like and also the because it's a randomized trial, there's a lot more of when you get those statistical significance from a randomized controlled trial. The only thing you have to be concerned about is there was maybe something went wrong in the trial, that maybe people got unblinded, for example, and then they got scared and they showed up at the hospital, and and that messed up, and so the reason for it isn't even the drug. It's because there was an unblinding that happened by accident, and it led to the result, and it's not actually the drug. So there's, by saying it's a 97%, it's more or less it's saying if they did the trial again, that's probably what they would see. That's probably what we'd see. But there's always you always have to be open to the possibility that things are wrong until they've been really done over and over again. Multiple different studies, all finding the exact same thing. Then you go, sir. Then you're like, okay, now I'm feeling pretty certain. You did it over and over and over again, and now it's like, okay, why? Eventually, to the point where people start wondering, why are you guys still doing this study? Why are you guys doing it again? There's no reason to do it again. We already know. And then someone does it again, and we see it again, and that's when you go, okay, this is pretty certain. But one study, I think it's, and people that's a very big problem, is people think one study and it's too much. It's not reliable. You have to be a little careful.
Mm-hmm. No, we did plan on talking about this paper here, Joseph, as well. Excess mortality.
Perfect connection. Perfect connection. Actually.
Yeah. It's strange, isn't it? I mean,
Yeah.
Things like myocarditis, for example, that you mentioned, is going to increase the excitability of the heart muscle, the myocardium. That is going to make it more likely to go into an abnormal rhythm. Some of these abnormal rhythms can be life-threatening. I mean, there's kind of biological plausibility, I think, here. But talking about excess deaths in general, I mean, how have you observed the trend over the past few years?
Well, I think that, as we move into this study, I think that it's pretty much a general trend that I think that there's a lot of different ways to look at excess death, and it's not just like a factual number in terms of like how many people died last year. That's a number. That's essentially should be a real number of how many people actually died. There's a body in the ground. Excess death's an estimate. It's an estimate of what do we expect people to die. There's a lot of different ways to do it, and so, but every way that it's been done, essentially what we see is in 2020, 2021, and 2022, there's been an increase in excess mortality in almost every Western nation in the world.
And 2023.
And now in 2023 as well, but I think probably the data for 2023 is probably it's probably finished and probably pretty secure.
I mean, certainly the first 40 weeks,
yes.
The data's pretty
exactly.
promising, yeah.
So yes, we're also seeing it in 2023. But so it's consistently found. There's between the different methods that exist, there's going to be some differences in the estimate exact number and the exact percentage but I'd say there's general consensus across the field. So I'm like, as before, what we talked about before, can we be certain that there's been an increase in excess mortality in general across Western nations? I think we can be certain. that has happened. More people have died in the last 3-4 years than we would expect if nothing had happened. That I think is pretty
and this BMJ paper alone covers 47 countries. So
Yeah.
it would be a bit strange if a similar trajectory were happening in 47 countries all at the same time.
Yes.
Does the fact that we see this trend in so many different countries point to a potential common etiological cause in the excess deaths?
Well, I think for certain, there's no question that COVID-19 played some role in this. But what we know is that COVID-19 and our various responses to it is, so there's, when we talk about the difference in deaths between 2020 and the years before, I think it's quite obvious. There's only a couple of things that could be causing that excess mortality, and it's things that we did differently in the world, plus a virus that didn't exist in the world. And those things all come together to probably, some of them probably created excess death. Some of them probably actually decreased death. And figuring out actually what is like fully responsible for everything I've spent a lot of time looking at it. I thought I was going to be able to really pull it, and it's not an easy, it's just not an easy question to answer. So what is exactly causing how much of the death, and it may vary a little bit between country to country, but we can presume that it's something that affected all the countries, and that's kind of what this study is essentially. They're exactly the point of the study where, they did a study looking at excess mortality, and they found that there was excess mortality just like everyone else did. Their estimates probably a little bit different than everyone else's. And that's bedrock of science, just confirmation study that identifies a thing that we've been seeing, and they're just doing it. They're even using a methodology that someone had already used, but they used it just for a longer, across a little bit further time, and maybe across a different set of the exact countries that they used initially. So that's the bedrock of science. This is classical, this boring classical science that we just do day to day. You're just like, yep, found it again. Great. Everything I believed previously isn't incorrect, because if they found no excess death, that we were totally wrong, then we'd be like, what? Wait a second, let's double check this. What'd you do? But they found exactly what everyone else found.
And quite high percentages. 10 to 20%. It's like a huge number of human beings potentially.
Yes, I think it was about 3 million. 3 million people, I think they were suggesting is about
in
the number.
States.
No, it's a pretty high number there.
Yeah, it'd be that in the States, I think. Yeah.
It's we're talking about millions of people. Millions of people dying who aren't supposed to die. So this is a pretty serious topic, and it should be getting incredible level of scrutiny by our governments. And think about COVID-19 and how our response to COVID-19 and the amount of money that we spent in our response to COVID-19, and this excess death rate is, we know for sure. And so the problem here is that, not from this study, but from other studies, what we know for sure is that COVID-19 is most likely responsible for a large percentage of these deaths. But we also know that something else, there is something other than COVID-19 that's also causing these deaths. And there's very different estimates based on how much it's COVID-19, how much it's not COVID-19. You can find some studies maybe that suggest it's not, that it's a large majority of it, maybe like 80-something% are COVID-19, but that's still 20%, which still would be a very large number of people. But then you find ones that are much lower. And the reason why you're going to find that is because how many people died of COVID-19 is not a real number, in the same way that we know how many people died last year, just died of anything. Like, you're dead, you're in the ground. That's a fact. Dying of COVID-19, in fact, every country has a different definition of what it means to die of COVID-19. How long ago was your positive COVID test? Each country has a different rule. Some countries, like for China, for example, you needed to have a CT scan of your chest that showed that your lungs had the pathognomonic lungs that looked like a COVID that should kill you. That's probably fair. They're probably correct, but they're probably being a little bit over the top and probably leading to an undercounting of their COVID-19 deaths. And then other countries are saying if you had a COVID-19 test at any point in the last 60 days, we're going to call it a COVID-19 deaths, and that's probably going to overcount it. And so it becomes, you're going to lead, so studies become, what they mean is not so clear cut. People are reading studies saying, oh, I found this in this study, but you got to know a lot of the details. And the problem is to do that across 47 countries. It's real hard. And then there's the way the test was run. The way this test was run, different countries ran their test slightly differently. And there's a threshold, a number of cycles that you would run a COVID test through of when you say it's a positive or a negative. And depending on the number of test cycles that you used, that would change the number of COVID deaths in your country. So it's just also, there's uncertainty on this.
Yeah, in my country, a lot of people diagnosed with COVID, especially in elderly care facilities, were, in my view, prematurely put on end-of-life care pathways. Things like morphine and benzodiazepines were given, and I think there was a significant argument that artificially increased the apparent infection fatality rate in COVID, at least in 2020.
Yeah, I've heard about this concern, and I believe it's possible. I also have heard the concern about early intubation, and as a concern that led to a large number of deaths, and that's something I could speak to much more closely, because if there was someone early intubating, that was me. I was in the ER, and that was what I was being told. That was a message that was being told to us in early the first surge, maybe through summer. I actually became very disillusioned with it personally, because it didn't look to me. I noticed just anecdotally that it looked to me like the people when I listened to people who were saying do this, and I did do it because that's what people were. It's a do virus. No one knows what to do. We're doctors trying to do our best. When you hear a bunch of physicians, and this is all that we had at this point, is there's a couple studies, but mostly this is we're seeing it. We're trying to put it together as fast as we could. People are saying this might help. Anecdotally, it didn't look good to me. It looked to me like there was actually, I felt like a rapid decline that I was witnessing from early intubation, and I became very suspicious of it early on. And also, I noticed that in the Chinese literature, which is believe at your own peril of but they were suggesting very clearly in their data. They said it's going to be your instinct to intubate these patients early. We have learned that is a bad idea. Yep. And we recommend against early intubation. And they were saying that in March. The Chinese papers were saying that in March. But we weren't in the Western world. We were only listening to Chinese recommendations on lockdowns and not on their early intubation stuff. Very
strange.
Yeah.
Did the authors of the British Medical Journal paper, did they feel free to discuss the potential causes of the excess deaths? Did you get the impression that this was an open discussion, or did you get the impression they were sort of working under some constraints as to what they could say?
I think this paper is, it's general finding. Like I said, it's a finding information that I know you've been speaking about on your show for several years. Of excess mortality. It wasn't news to you when you read that paper. That you said, oh, we weren't surprised. And
I was surprised that it was in a peer-reviewed medical journal, to be fair, because very often the data that we've been analysing on my channel, for example, didn't make it into mainstream media or peer-reviewed medical journals. Well, so it was in a sense, I was relieved to see it.
Yeah. Well, the reason this paper has made a splash is not because of the data that they found in their study. It's because, the way a scientific paper is written, as you've read, I'm sure, more than you can count. And For anyone listening, we have a very systematic way. We have an intro, then there's a method, then there's a result, then there's a discussion. Every once in a while, a journal puts the methods after the discussion, but that's it. That's the only way that we do scientific papers. And if you're reading a scientific paper and you're familiar with that field, you read the intro. And the intro is telling you all the things you already know. It's like, hey, you know this. This is what we're about to give you a study about a thing you know about. And intro typically is just more of things you already knew. You read the study, you see the results, and then the discussion is typically like, hey, what are some implications of this? What do we have to think about? What's the next place to look? What should we study next? And this study apparently seems to have gotten itself into some sort of a controversy by just writing a very standard scientific paper, by stating these obvious things. So they say in their intro, excess mortality has been happening since 2020, 2021, 2022.
Patently true.
Yeah, and then they say there's some things that have changed since 2020. We have COVID-19. There's been lockdowns, and there's been a COVID-19 vaccine, and all of these things have been have been introduced to our populations. And there's reason to believe that each one of these potentially is part of this excess mortality. And they offer evidence.
Obviously true.
Yeah, these are all obviously true statements.
Completely, yeah.
And even when you read the critiques of this paper, which there are many, they're suggesting that they're saying that the COVID vaccine's causing all the excess deaths. That's not actually at all what they claimed, though. And then they went to their discussion and they essentially did the same thing. They said, we found excess deaths. Let's review some of the things that could be causing it. And they go through the evidence on it. And, if the authors are listening, I would like to say thank you. I appreciate the reference.
Absolutely.
That was very nice of you. But they were just simply these are obvious statements. We had these 3 changes. And if there's other changes to throw in there, propose them. And until our governments figure out really detailed what caused this excess death in nearly every country in the Western world, all 3 of those are on the table. All of them. And there's just no debate about it. And like that, there's no way to say that one of those isn't correct. All of them are possible. And people get confused here in that they think that they could take a single country and say, for example, this country did this. And I'll give you a good example, right? So some people use Sweden as an example to prove that the lockdowns were harmful because they had low excess mortality, and then they say that their excess mortality is lower than most of the Western world since in 2021 and 2022. And it's been argued that this is demonstration that the lockdowns caused the harm and not the vaccine. Now, it's not possible to take a single country and make definitive statements like that with any level of reasonable certainty, because if you think about the world, things that cause people to die or live is a very complex situation. This is a very complex scenario. We had the entire world change everything in how we do things. And every country had lots of laws and rules and recommendations and all sorts of things that were introduced to our populations at different times across different, and you can't just take one country and think you can prove or disprove. It's not possible, because it's in fact likely that whatever you think is causing it in that one country, if it's the only one, if you only got 1 or 2, then like that, there might be something else. Because what you have to look at are general trends, because all of the countries have done hundreds of different things differently. Because like imagine a country changed its speed limit, right? If they up the speed limit, there you go. Maybe that was their excess. Maybe they decreased the speed limit. Unless you have to know every law on the book. it's incredibly difficult to just use one country. If you, and I'm using speed limit as an example because it's something that I presume most people didn't look up on a country during this time period. Maybe one country decreased their speed limit, so they decreased excess mortality in their nation by that, and so it looks like whatever they did, they were a really good masking nation. They masked a lot, and so it shows they had decreased. But actually, it was because they decreased the speed limit across the country by 20 miles an hour. So you have to understand that there's a lot of pieces to the puzzle, and whenever you try to simplify it, you're displaying an ignorance of understanding this complexity, and you really just we need to be focused actually as a world, acknowledge that there's a serious problem here. We can see in 2022 there's a massive number of excess deaths across the Western world. And we know that that was not COVID-19 because Omicron did not kill people in the way that the other ones did. So no matter what we're going to say about 2020, 2021, I personally think that 2020 was almost predominantly COVID-19. And I would agree that our intervention to it, I'm sure, impacted that. But I will give, I guess I'm biased as a physician, but I think I personally I think that we have to give physicians a break, that they didn't know how to perfectly treat a disease they've never seen. And it's, while yes, they may have made mistakes in their treating a never before seen virus, but how could they not have made mistakes? Like it's asking too much of human beings that we could just have known everything. While there's some things you could identify that there was so much information happening at that time. I think but it was related to COVID-19, and maybe some of it was our response, doctor's response, that led to deaths that I will agree there were probably some that were unnecessary. But I think we have to be a little lenient. We have to be lenient, I think, on that moment in time, because it's hard. Also, the midazolam and morphine, for example, right? If you are dying of shortness of breath, right, and the doctor there is looking at you, and they understand that you're dying of shortness of breath, and they understand, they think that the most likely scenario here is you're a person with Alzheimer, like you were saying, like a nursing home patient. They're looking at you. You're intubated. You're in the ICU, and they go to the family and say, "I don't think they're going to make it. I think we should try to make them comfortable." And maybe they had a chance of making it. Maybe it was a small chance, and maybe they could have saved more people. But if they did that, then they just went full go and aggressive, like treating it in the way that to get them through it. It's likely that then a lot of people would have died starving for air. I could only imagine how anxious a person feels in that moment, and the pain of the air hunger when you can't breathe and you're dying of not breathing. And the doctors there were giving drugs, midazolam and morphine, to make so that when people did die, they at least didn't have a death that was a medieval torture.
Which, of course, I would completely support. But
yeah,
in the UK, we had a lot of people given midazolam and morphine who only saw the doctor on the mobile phone and certainly weren't intubated, and sometimes didn't even have oxygen therapy available in care homes.
That's
that's
different. Okay,
yeah.
I see what you're saying. You're saying there's a point where you need it, where it's good, and you're saying they may have been they may have pushed it a bit harder than they should have.
I think you and me know where that point is. When I know a patient, I know when it's appropriate to move on to a syringe driver.
I agree, but I believe that, to be totally fair, I think when you're dealing with a patient, that where you decide to make that decision and where I decide and the next guy, there is some difference. I think there's ones where we'll all 100% agree.
Yeah.
In one way, 100% agree in the other, and then there's going to be a gray zone.
Sure.
And it's plausible that maybe I personally didn't see that happening from my perspective, because it would be, in my perspective, it was an ER and ICU.
You're in a sophisticated hospital, so.
No, I'm in a rural
Well,
hospital.
you're in a proper hospital, though.
No, we have the technology. It's a rural hospital. It's not.
Oh, you always become cynical of your own work environment. That's normal. But we
It's a
don't want
great
to upset
hospital.
you.
The hospital's good. We're good.
don't-
We treat our patients well, and our patients love us, and we love them.
That is the
But
main thing.
we don't have ECMO. We don't have we don't we're not using the next level of things that I'm not even sure if they even work. So,
I'm pleased to hear it, to be quite honest. Now, sadly, I had my last vaccine as late as 2021. Do you think I'm still at risk from longer term adverse reactions?
oh, I mean that's no one knows. No one knows that answer. I mean it's
Well, what's your gut tell you on this, though? You're a doctor, what do you feel? Because I get asked this question all the time.
I think that any insult to the body has the potential to have a long-term implication. And so it doesn't really matter what it is. It's just it doesn't mean that every insult to the body has a long-term implication, but every insult to the body has the potential to have a long-term implication. Like the myocarditis thing is the most obvious of problems, right? And I have a friend of mine. He was an old colleague. We studied neuroscience together and worked in like sister labs. And he's a runner who would do the 100 mile crazy people run. Run 100 miles. I think it's like 20 something. It takes over a day. It's a crazy idea. Like I don't know, the ultra marathon idea. And so he did these for years. And he calls me one day and he says to me, he's like, man, I think I got one of the vaccine injuries. And I was like, oh, what happened? And he's like, well, I can barely run 5 miles. And I was like, well, dude, I can't run 5 miles either, man. That's a lot of miles. And he's like, no, but I can normally run 100 miles. And I was like, oh, yeah, I forgot. Yeah, you run those ultra marathons. Oh, that is bad. That's weird. And so he is in a category of a person who uses his heart to do an extreme thing. And so we notice actually that there's lots of athletes that have noticed this is anecdotally. I don't have a real data point on this, but it happened to my friend, and he said this to me. And so he had some insult to his heart. Was it myocarditis? I don't know what it was, but something. Did it make his legs weak? Maybe. I don't know. But he couldn't run 100 miles anymore. He now only could run 5. It's a dream. A dream of mine is to one day run 5 miles. I should maybe take the vaccine and I can run 5 miles.
But I wouldn't recommend that. But okay, yeah.
But then I didn't hear from him for a little bit, and then calls me a couple months later. I don't know, maybe 8 months later, and he's like, "Okay, Joe, it was definitely the vaccine." I was like, "What do you mean?" He's like, "Well, couple months went by. I started getting back up there. I was running 20 miles again, and like I was able to do a marathon, but like I still couldn't. I never got back to 100." And he's like, and then my wife like really was pushing me to get it, and I didn't want to because I was scared about what happened, but she pushed me. I got it, and I'm back again. Now I can't run 5 miles again. And I was like, oh well, it happened twice. Then that probably is you probably found something then. Then that we can say that the repeat offense is the likelihood. And now, so he can notice that. If I can't notice, if you took the vaccine, if you don't run if you could even for a runner, right? If you're running 3 miles and now you're like, man, I could barely make it to 2.8 miles. It's kind of not really something where you're just like, oh, am I getting a little older or like, what is it? But, it's like, because he's such an extreme level of a sport thing, so he has something where he can notice something that we can't. And so there's implications of anything that's harming the body that has long-term implications, and we don't know. But I don't want to suggest that it's definitely doing that. It's possible that it, and also he improved. His thing was improving over months, and it still, I know, has improved since that time. But he's not run a 100-mile marathon since that, still. And to my knowledge, I don't think he has yet.
So the FDA has approved the respiratory syncytial virus vaccine in messenger ribonucleic acid form for the next, well, basically for next winter.
Wait, are you, a messenger RNA vaccine?
It's an mRNA respiratory syncytial virus.
They have not
vaccine.
approved it.
No, I think the FDA has approved that one, as far as I know.
Are you really? Okay,
Yeah.
I know that they've approved an RSV vaccine, but they have approved the messenger RNA RSV vaccine.
There's an RSV mRNA vaccine, as far as I understand it, has been approved.
Yes, there is one. I thought it was still in trial though.
No, I think that one's
Done.
approved by the FDA now. The one that's still in trial is the combined COVID and influenza one. Mm-hmm. And then they've got mRNA vaccines coming through for
the season.
Half a dozen different conditions.
For fall, it's coming out for fall, I presume.
Yeah. So, any concerns about that?
I mean, look. Obviously, I'm not familiar with the study they used,
but just the idea that that more mRNA vaccines are coming out. Do you think the vaccine side effects that we suspect happened were specific because of the spike protein, or do you think there could be some fundamental issue with the mRNA technology? I mean, I would like to see a moratorium on mRNA vaccines until we know a lot more personally.
I don't know, and RSV vaccine to me is a wild, it's beyond even a messenger RNA issue. RSV is a disease that young children get, and most children do perfectly fine with it, but it does lead to some there's a couple serious cases and that are real, and they end up being hospitalized, and this is in children.
In children, but this is being recommended for adults. I mean,
yeah, and so
let me ask you a second question. Do you see, as an emergency physician, a lot of people 65 plus coming in with RSV pneumonias and problems? I mean, I can't say I've ever seen it.
Well, I find it incredibly strange that RSV, being a killer of old people, is being introduced as an idea, and the reason for this is, it's. I don't want to deny that it's not true, that it's even. I don't know if it's really much worse than any other virus that is killing people, that kills elderly, fragile people, where anything, a strong wind can take them out, but as an emergency physician,
I must have been exposed to RSV all my life.
We all have been. It's a regular. Yeah. We're all regularly exposed to it.
So I've certainly never seen anyone come into emergency department with a. I mean, a viral sepsis is very rare, but I can't remember ever seeing an RSV sepsis coming in, and yet they seem to be wanting to vaccinate us old people against that.
I find it strange because emergency medicine, our entire specialty, is built on being able to identify the people, the needle in the haystack, the people who we think are at risk of dying, pulling them out of a crowd of people who are not about to die, telling those people to go home, finding the ones who are at risk of dying, and then saying, even though you don't look that sick necessarily, you have this, and that's a risk for you dying. And I find it shocking that from forever, we were never testing elderly people for RSV. No one in emergency medicine that I could think of were suggesting that we have the test, we use it in children. Because of that exact thing, and that RSV in children is not exactly like another cold. It can cause a serious breathing condition that leads to a hospitalization, and we have to guide the parents to be scared of that, so they come in when they see it. And so that's why we test this in children. But I'm just shocked. I'm shocked that the field of emergency medicine across the world, to my knowledge, was unaware that this was a thing in the elderly that we have just been missing. We had the test, we easily could have done it, and then coincidentally, this concern of RSV being this killer in the elderly, it just so happens to be introduced as a concept exactly when a vaccine is released. And that to me is I mean, they could be right. I'll be honest, I haven't properly gone through all the data, but I'd say, shame on the field of emergency medicine for not identifying that RSV was this major killer in the elderly beforehand, despite so many great tens of thousands of brilliant minds in the field of emergency medicine. Not one of us was recommending to test for this. And we missed it. And then a vaccine company came out with it, and they showed us. Well, they didn't show us that their vaccine reduces hospitalization. They showed that I think it did reduce. I mean, maybe some symptoms of the infection, but
Well,
they didn't
it'll certainly produce a few antibodies.
Yes, for sure. But I mean, if they could show if the vaccine reduces hospitalization, reduces all-cause hospitalization, I don't need much more information. You don't have to be that smart. If it's reducing all-cause hospitalization, that's it. We're done. You did it. Good job. Congratulations. You reduce all-cause mortality. Holy, let's pop the champagne. Everyone go and get this who were in that study. Yeah.
But strange that none of us knew about it before.
Yeah. It's also strange that our regulatory bodies are approving drugs and vaccines without without asking the companies to obtain the outcome that's actually essential to determine if it's a good idea. Because if you're over 65 and the CDC recommends the RSV vaccine to you, I mean my question would be, oh, okay, well, does it make me live longer? We don't know. Actually, we didn't study that. Okay. Well, does it make me go to the hospital less? No, we don't know. You might go more. You might die more. You might die less. We actually didn't study that in the randomized trial. Okay, so what do you know? It makes you less likely to get a cold. But I get colds. That's pretty. Is it going to make me sick the day I take it? Yeah, it probably will make you sick the day. So I'm trading a day that's guaranteed to get sick for avoiding a cold, and that it might not help me avoid Why would our drug regulatory bodies approve drugs, any drug, any vaccine, that without demanding that these companies do the proper study to figure out what everyone wants to know, so that we are not here battling over observational data that we can interpret all sorts of ways, but basically we're just going to live in total uncertainty. Make them do two studies, and you know what? Then you guys do the study and confirm that their study was correct. Why introduce these drugs into the population that are potentially hurting people, unknown real benefit, and this is commonplace within all. This is not just the COVID vaccines. This is across the board for many drugs, especially drugs that are supposed to save lives, drugs that are supposed to make you live longer. If the trial doesn't show it makes you live longer, we don't know if it makes you live longer. So every trial that's designed to do that, if we don't want to know, then let them do a trial. Avandia is a great example, a diabetic drug. It reduces glucose. It makes people's glucose down. And the real reason we want to keep people's glucose down is, at a good level, is essentially diabetics, high glucose causes heart attacks. That's bad. That's the major thing. It's also, don't get so high that you go into a diabetic crisis, and, don't get amputations. There's more than just heart attacks, but heart attacks is the major problem of diabetes.
The main cause of death, yeah.
Yeah. So the purpose of these drugs is, we could say it's almost stopping heart attacks or stopping the serious things. Avandia does reduce your sugar, but it causes an increase in heart attacks. So why did it take so many years for us to give that out to people? And actually, I think it might even still be on the market. But it's craziness that people think that these trials are not possible. They're totally possible. Our drug regulatory bodies are not demanding them. And the companies are going to get away with as much as they can because they don't want to test their drugs, because it's really hard to make a drug that works. It's easier to make a drug that looks like it works on an outcome that isn't exactly the outcome we care about, but it's related to it. That's so much easier to do, and then you can make a lot of money and not necessarily achieve the outcome that you want.
But it's interesting that this new vaccine's been approved for a problem that you and I didn't know existed.
No, I've never heard of anyone mention it before.
No.
I want to give a caveat on the thing I just mentioned. Our regulatory body tends to be much better on drugs that aren't for life-threatening conditions, such as dermatological conditions. They force the companies for dermatological drugs to like really demonstrate kind of like quality of life, that their quality of life is better overall. I think that's generally for the dermatological conditions. But I know the FDA, I don't know about the other countries, but the FDA has very specific rules when it's for life-threatening drugs. And it changes the way that they can approve things. And they say, actually, okay, you don't need to like really prove that the drug is doing what you're saying it's doing. You could just go one step below that. And so almost all of our cancer drugs are approved on this. And it's been, the reason that this has been allowed is because I understand that, I've had relatives who, close family died of cancer. And I understand that moment in time when you've gone through every single thing that we know that works. We know you tried the worst one, you tried the second, now you got the third, and then they're saying maybe go to a clinical trial or, it's probably going to fail. And that's a brutal moment. And there's this idea that if we just let these companies release this drug, a cancer trial, how long do you have to wait to find the difference in death? Not that long. So, and they get confused because they're like, oh, look, it makes the tumor smaller. And you're like, but if it makes the tumor smaller and then everyone dies of liver failure, that doesn't really matter because I didn't really care about the tumor size. I cared about living longer. Yeah. And so if we don't do the right study, then we release this drug that we just don't know if it works. So like we think that we're doing a benefit to these families by getting the drug out there because it helps their hope. But like if you're like, hey, here you go. Here's this drug. We don't know if it makes you live longer. Like, and we released it early. So now when your child gets cancer in 30 years, we're still not going to know if this drug makes you live longer. And he's maybe going to have to take it and we're still never going to know because we didn't do the proper trial. Like we have to be a society that's smart enough to understand that, I'm sorry, people are going to die and like that's a shame, but like we have to consider like our next generation, that we have to do these studies properly, or we're just going to have a drug supply. All of our drugs are just going to be a mystery of nonsense and side effects, and we'll never know if their benefits outweigh the harm. And if people want to live in that society, then we could keep approving drugs before we actually discover if they work or not. And that's good for industry. It's just not good for society, but it's very good for industry. So as a society, we have to decide. In a democracy, we are supposed to be able to decide. And I believe that the only thing that needs to be done to fix this problem is the political will. We know how to do it. Even if we went back to the rules from 20, 30 years ago, it's not like we have to invent the new rules. We can just say, hey, just cancel all the things we did in the last 30 years because you started approving drugs like crazy. Just go back 30 years and we'll do a better job. And so it's not even like we need to invent this. We just need the political will to push our politicians to demand that our regulatory bodies do their job and regulate an industry, and allow the capitalist market to function when they are operating under the proper rules. Force them to make a drug that works. They will. If we force them to, they will. But if we don't force them to, they won't. That's just the reality. Yeah. Yeah.
Excellent. Dr. Fraiman, thank you so much. We could go on for days, but
Oh yeah, for sure, for sure.
I know you've knocked your AC off, and it's the ambient temperature there is higher than normal blood temperature. So
Yeah,
we
it's
certainly
definitely over.
appreciate it.
It's over 100 in our, yeah, which is actually kind of
Louisiana,
nice. It's a nice, 100% humidity, 100 some 8 degrees, and yeah, our summers are rough here.
Yeah.
Yeah, some.
Listen, do you get many patients in with alligator injuries?
Actually, it's interesting. The truth is no, we don't.
Everyone knows about the danger, do they?
Yeah, it was funny. I only seen, well, one time actually, an alligator got into our hospital, and everyone there, the Cajuns who I work with, they just grabbed it. They just grabbed it, taped up its mouth. The nurses were treating its wound, hit him some wounds on its leg. The nurses treated the wounds, and they let the alligator go back out.
I've actually seen that in Cambodia. They just grab it, tape it up, and take it away.
Yeah, and then, but I've seen oh no, I've seen two. I've seen two alligator, like legit alligator injuries over 5 years, and one was in a guy who, I think it sort of explains it. It's a guy who was surveying the land for some company, like doing for a corporation. He was surveying a land, and he was like, yeah, so I was there and doing it in this area, and like the patient behind the screen next door, he's like, oh, you were there during nesting season. Everyone knows not to go down the swamp during nesting season. I was like, wait, everyone knows that? And I walk outside of the room. I was I go to the secretary. I was like, hey, can you go to the swamps right now? She's like, no, it's nesting season. Like, everyone knows you can't go. I was like, oh, everyone, I guess, does know that don't go there during nesting season. That's when the alligators get a little violent. And
but coming from New York, it wasn't it wasn't a common problem.
Yeah, we didn't have them in New York. Even maybe in the sewer systems, but I'd never seen any.
Yeah.
But yes,
do you get a lot of snake bites?
Yes, but they're not particularly like we do have poisonous snakes in Louisiana, but
well, it's a swamp, isn't it?
Yeah, we do, but they're generally not. They're not terribly poisonous. They're not like there are certain regions where it's much more extreme. Our swamps actually it's pretty friendly. Actually, the people there love it. They love it. They make a lot of great food out of that swamp. So
yeah.
And they really do enjoy the area. And it's beautiful, actually. It's funny. The swamp's thought of like a gross place, but it's sort of like a rainforest. We used to call a rainforest a jungle, and it was a terrible, gross place. And then it got a cool name, magical rainforest. And now everyone thinks it's beautiful. The swamp's similar. Like a rainforest, you don't want to go like live. Like maybe you could set a tent up there for a little bit, but it's not like being in a nice mountain forest, like dry forest. Like you're gonna end up with like bug bites the size of your head, and it's kind of rough, but there's a beauty to it as well. And the swamp is, I think, it has a similar magic that like a rainforest does.
Or part of the created order. Yeah. Great, Dr. Fraiman, thank you so much. And anytime you got more work to tell us or any ideas, you're always welcome, of course.
My pleasure.
Fascinating as always.
I'll give you a ring,
Please do.
Okay.
Thank you.
Pleasure.
Thank you.